everyone. My name is Marianne Huff. Welcome, everybody. So glad to see everybody joining us for the second installment of our integrated care series. Today, you're in for a real treat because we're going to get Integrated Care 101. We're really happy to be able to present this series, given the conversation that's happening in our state about integration of behavioral and health care. We felt it was really important to do this series. So for those of you that joined us the first time last month on March 9th, you know that we kind of talked about the results of a survey we had done. We had taken a poll and we presented those results. And then Dr. Pinheiro talked about why do we need to have integrated care. Today, we are going to have Integrated Care 101. Next month on May the 4th, we are going to put together kind of like the third webinar, which will be an amalgamation of all these things we've talked about, the first webinar and the webinar today. If you were with us on March 9th, you know that we had sort of this open discussion about integrated care, because one of the things that we wanted to know at the Mental Health Association in Michigan, we were really interested in knowing what people actually know or do not know about integrated care, and whether or not individuals were interested in having their care integrated. So Dr. Pinheiro is going to share some of the data with you from some of the polls that we took at that particular webinar. What I'd like to do now is I would really like to introduce to you Dr. Angela Pinheiro. She is a nationally recognized expert in integrated care. We're really fortunate to have her because she's a Michigan resident. She graduated from the Michigan State University Psychiatry Residency Program in 1990, and then subsequently obtained her Juris Doctor from Michigan State University College of Law. She's worked in the community mental health system for over 32 years as a psychiatrist and is currently the medical director of CMH for Central Michigan. She's also an active member of the Medical Director Institute at the National Council for Mental Wellness and is a certified psychiatric trainer in Michigan's first episode psychosis program. Prior to entering psychiatry, Dr. Pinheiro was an internal medicine resident program, giving her a sound platform to understand the need for integrated care. So I'm going to go ahead and turn it over to Dr. Pinheiro and welcome her. Thank you.
Thank you, Marianne, for that kind introduction. Welcome, everyone. This is Integrated Care 101, and this slide is for all of us who are hoping for spring and being able to take long walks outside. So this is the polls that we took at the last meeting. The first question that we asked was, do you know or understand what integrated care is? And 25% of respondents said they weren't sure, and that's a very important percentage that we're going to come back. Majority of people said that mental health care was important or very important for themselves or their family. So do you want your health care integrated? And again, 25%, and I assume it's the same 25% said they're not sure. They need to find out more, just highlighting the importance of more education on what actually is integrated care. This one is interesting. The majority of individuals thought that mental health was as important as physical health or at equal importance. The bottom slide there, would you want your medical doctor to ask you about your mental health needs at every visit? You see that there's about 19% or so that were not sure or said no. And that's something that we really need to understand. What's happening that people are feeling uncomfortable, even though they would like their care integrated, they're feeling uncomfortable having the physical health physician or provider ask them about mental health. So this is just a brief review of what we talked about last time. Why integrated care? We mentioned that many medical conditions, common medical conditions, including asthma and types of cancer, and we gave a whole list last time, have co-occurring mood symptoms. And if those mood symptoms are untreated, you have increased morbidity and mortality. That's extremely important. So this is in the physical health realm where you're seeing your medical physician if you have any kind of chronic condition and co-occurring mood symptoms, even if they're mild or moderate, you may have increased complications. And of course, we all know that individuals with SMI die 15 to 25 years prior to their peers and from common and preventable medical conditions. So that's why integrated care, both at the physical health system as well as in the mental health system, is extremely important. So what is integrated care? It's basically putting the body and the brain back together. Focusing now only on the behavioral health setting, why do we have this high early mortality for individuals with serious mental illness? And it's not just individuals with schizophrenia, but research has shown that also individuals with bipolar disorder and maybe even borderline personality disorder have an early mortality. And the literature has shown that they have a lower rate of routine preventable care, so lower rate of getting mammograms, colonoscopies, having their blood pressure checked. They also have difficulty in recognizing early symptoms. So I had a very nice and engageable young man who had schizophrenia when I was working at CMH in Lansing. And one morning he called up and said, "I don't think I can breathe. What should I do?" The ambulance came. They had to intubate him there, took him to the hospital. He remained intubated on a ventilator several days. His chest was full of non-Hodgkin's lymphoma. Most of us would have recognized that there was something wrong prior to having to be intubated. It also works the other way. People with chronic conditions like, asthma or anything else may attribute some of their symptoms. If they have co-occurring depression, they may attribute their depression symptoms to the asthma. And again, if the physical health provider does not clarify and screen for depression, you're going to have missing a diagnosis. Last time we talked about the imbalance between the capacity, everybody's innate capacity to deal with life and stressors, and the burden of illness and treatment. And individuals with SMI are much more apt to develop that imbalance because of all of their needs and all that we expect of them. They're less likely to obtain evidence-based and aggressive treatment. I had an individual who, because he was very psychotic, he was refusing cardiac surgery. They put him on palliative care. He developed COVID. He was extremely ill. They would not admit him to the hospital. That would not have happened to you or I. And there's a lot of literature supporting that our consumers or patients don't have the aggressive treatment always available to them. Of course, they have increased lifestyle risk factors with increased smoking as well as substance use. And there's a lack of coordinated care or integrated care. So what is the basis of integrated care? And again, I'm just talking from the behavioral health side, is to screen, to identify early symptoms and conditions, ensure that care coordination occurs, and that the standard of care for treatment for that condition is met, and then supporting the consumer in both getting the standard of care treatment as well as obtaining routine preventable care and modifying the risk factors. It's really simple. You have to do these three things. So those are the essential components. And as Marianne mentioned at the beginning, the Center of Excellence and SAMHSA are publishing a paper that should be out next week. We've been promised it for many months, but it should be out next week with MHAM. The name of the paper is Designing, Implementing, and Sustaining Physical Health and Behavioral Health Integration. And it's a comprehensive healthcare integration framework, or CHI or CHI. In that paper, they outline the specific components of those three things that I talked about that are very essential elements and set the standard of care for integrated care. How the components are put together may vary, but there isn't like 100 different models of integrated care. There's one model with essential components that have to be met. How you put them together may be different. So is this new, what SAMHSA is putting out? And actually not so new. Many of us may remember the 4 quadrants, which was initially published around 2006. And then the six, on the right side of the screen, the 6 dimensions or levels of integrated care with the focus of having physical health and behavioral health together in one clinic. And that was published in around 2013. And all these things emphasize the same thing: no wrong door, the importance of screening for physical health, obtaining evidence-based treatment, standard of care treatment, care coordination, paying attention to social determinants of health, team-based care, and looking at population health. So back in 2006, the National Council and SAMHSA were already talking about these components. But there's been a real lack in implementation. The paper talks about barriers that they feel were important in the slow implementation of integrated care. They thought that the previous models lacked flexibility. They lacked appropriate bidirectional measures to measure how integrated you were. They lacked metrics that connected the progress in your level of integration to value, so you could discuss that with payers. And there was a significant lack of finances to support either implementation or sustainability. I would add that there was also the lack of involvement of payers in the physical health system, in the design and the implementation of integrated care. Next slide. The paper, and you're getting a preview of what the paper is or what's in it. And what I hope to do is to make it more simple so that when you read it is very easy to understand, because there's a ton of material in that paper. So they talk about 8 domains. You know, I talked about 3, they divided it into 8, but it's basically the same thing. You have to screen and refer. You have to provide evidence-based treatment. You have to have continued care management. You have to provide self-management support. It has to be done in a team-based care. You have to do systematic measurement and quality improvement activity, linkage to resources to address the social determinants of health, and addressing the financial sustainability. And the paper spends a significant amount of time talking about financial sustainability, which I think is very helpful. When you see the paper, this is what the grids will look like. And they're very much the same as Henry Chung had in his New York papers that we talked about last time. So on the left-hand side is the domains, the 8 domains that we talked about. The next column is what are the sub-elements of that domain, or a more detailed description of what they mean by that domain. Historical practice, what we used to do in the past. And then there's 3 levels of integration, with the most integrated system being level 3 on the right. They give names to each one of these levels, but I found that the names were a little confusing in the beginning. So I'm just talking about 1, 2, and 3. So the 3 levels of integrated care, they're based on the population that's being targeted, the degree and type of intervention, the extent and type of care coordination, how the data is used, and how the measures are monitored. And a couple of slides from now, I'll give descriptions of what those mean. The purpose of having the 3 levels is to show movement. So it describes specifically what you need to do in each one of those domains to go from, for example, level 1 to level 2, or level 2 to level 3. So it's not as complicated as it looks. Here, again, is the population intervention coordination, data, and measures. So level 1, we're focused on individuals. Level 2 is subpopulations, or the team caseload. And level 3 is shared population across organizations. And that's very important. So it's you with the local health system looking at your shared population. The intervention in level 1 is fairly basic. 2, you increase the thoroughness. And 3 is comprehensive. The coordination, again, level 1 is individually arranged. Going all the way to level 3, where is kind of automatic. You have a care pathway and you have EMR interoperability. so it's easy to exchange documents. Data in level 1, you're looking at individual improvement, so that individuals improve over time with your intervention. And in level 3, you're looking at population health management. All that goes into that, and we're going to talk about that a little bit later. And really important is the measures. So in level 1, the measures are focused on process. Did the A1C get drawn to screen for diabetes? Was the blood pressure taken? Those kinds of processes. And in level 3, you're really looking at outcomes. So is the A1C under control? Good control, not marginal control. Is the percentage of individuals with SMI who don't have blood pressure under good control the same as what you would expect in the general population, which is about 10 to 15%. So this is, again, the grid that you see. Let's focus first on the screening, referral, and follow-up. So the screening, referral, and follow-up has 2 different subcomponents. You screen, of course, for physical health conditions and risk factors. And the second component is you facilitate the referral and follow-up. So here is the domain, which I highlighted in yellow, and then the components, which we just mentioned. The historical practice in the past, if the consumer said, gee, I'm having this kind of symptom, you would recommend that they go to their doctor. If they didn't have a doctor, you might help them get one. But there was no systematic follow-up after the referral unless the consumer brought it up, and it was probably not in their plan of service. Integration level 1 is you have systematic screening of high prevalence condition and risk factors. So do they have diabetes, high blood pressure, very common things. For the follow-up, you have agreements with physical health providers to facilitate the referral and how to share the information. And you may track the show rate. So again, a process. You made a referral and they showed up. Level 3, you screen for additional conditions or risk factors that are present in your population. So you have to know what's going on with your population. So for example, HIV might be high in the population where you are at and in substance users. So you may want to include that in your screening. And then you collect the positive screens and you do care coordination, and you may have a care coordinator in your team to make sure that the referral occurred. And you're talking about a closed loop referral, which means that not only do you make sure that they made it, but you get the report back and incorporate it into your EMR. And then level 3 is you do comprehensive screening, and you have registries to follow. You do stratification, and you have automatic data sharing and EMR interoperability, which we already talked about. But the most important thing here for me is that you have processes for share accountability for engagement. It's not like behavioral health, physical health refers to behavioral health. They don't show up. We call and say they didn't show up, and that's the end of it. You're sharing that responsibility and accountability, and you have an agreed process to do that between you and the physical health provider. And here's an example of the measures. Again, level 1, you're talking about process, number of referrals. Level 2, you're talking mainly about process, but you're beginning to talk about outcomes. So you may add how many people got controlled A1C, but you're still looking at the number of percentages of individuals with opiate use disorder who were prescribed MAT. So that's a process. In level 3, you are measuring outcome. Patients who were depressed who reach remission within a certain period of time, percentage of people who receive colonoscopy within a shared population. Even though that's a process, it's really focused on outcomes. So you could say percentage of cancers that were caught early or were treatable. So focusing on level 3, and that's really important because that's where we want to get to. So it's a shared population. Of course, you have to do this by focusing on individuals. Both physical health and behavioral health have skin in the game. So it's not like you send somebody to the doctor and, the first appointment, they didn't make it, oh well. And you have evidence-based comprehensive screening and treatment, shared registry, and data tracking. So you get together with a physical health provider, sharing the data and seeing how we're doing and doing quality improvement. So we talked a little bit about this already. You're sharing the data to identify gaps, not only within your system, but between systems. You do coordinated stratification by complexity and need to match the level of services in both behavioral health and physical health systems. So individuals, again, with that imbalance between capacity and burden, that occurs in the physical health side too. And we need to assist with that in the physical health side. You need to have jointly developed clinical pathways for standardization and efficiency that are outcome focused. And it's very important to do this together with, if you're interfacing with health systems, to do it with, the entire health system so that you don't have individual pathways depending upon the CMH geography. And I know one state who's implementing CCBHC, they're having a consultant help meet with all of their hospitals, so it's like 65 or more hospitals, with the behavioral health providers to have a single clinical pathway for transitions of care out of the medical hospital. That's absolutely fantastic. They both agree to it. They both know what it is, and it's standard regardless of where you are in the state. You have to have that partnership between physical health and behavioral health. And, the purpose is to provide one system of care where we're joining with the physical health providers to take care of the community and not just focused on our population that's coming to our behavioral health clinic or CMH, but really becoming part of the medical community. Value is extremely important, and you really, there's value in going from level 1 to level 2 of integration, but the most value is attained in reaching level 3. So level is outcome plus patient experience divided by direct and indirect costs. So the next thing to look at is evidence-based prevention and treatment. So the components are evidence-based protocols for health risk screening, evidence-based guidelines or protocols to address common physical health risk factors and conditions, recommended medications for common co-occurring conditions, protocols for screening, protocols on how to address it, and then dealing with common co-occurring conditions. So level 1 is you have basic guidelines for screening. You have basic training for the providers, and this training is extremely important. And having training that joins the physical health and the behavioral health, I think, is extremely necessary. For example, having all the nurses trained together. We're using the current evidence-based guidelines. Level 2 is routine use for universal and targeted preventative screening. So you're just doing more of it, and you have standardized workflows. Level 3, of course, you have systematic training. You look at outcomes, and you provide clinical decision support for the providers. Again, under the treatment, level 2, in-depth training. And again, to reach level 3, you have to be doing level 1, level 2, and level 3. Recommendation for common co-occurring conditions. One is smoking cessation, so routinely prescribing medications for smoking cessation. Level 2 is occasionally prescribing for SUD. And then level 3 is routinely prescribing for a number of co-occurring conditions. So again, that joint training, because standards change. For example, a couple of years ago, the blood pressure targets were significantly changed. So we have to keep up. So the next one is care management, and we have care managers do a ton of things. So we have to make sure that they're not overwhelmed and they have time to do their job. So continuing monitoring and care management. The important part of this slide is longitudinal clinical monitoring and engagement. So you don't do it once. You don't do it once a year. You have systems in place where you're monitoring and working for engagement over the time that they're your consumer, and all the way over to level 3, you're coordinating across the continuum of care. So when they go to the psychiatric hospital or when they go to the medical unit, you're part of that coordination of care and treatment planning. So it's really important that organizations must work together to develop the clinical pathways. Mentioned that quite a bit. I really like this cartoon. Okay, self-management. And what is self-management? Knowing yourself, understanding your condition, and knowing what you need to do in order to decrease that burden and increase your capacity. Under the description is use of tools that promote patient activation and recovery from co-occurring medical conditions. Level 1 is you have some patient education, some handouts. You may refer them to some web-based resources, and you really rely on the physical health system to provide more information about the condition and how for them to deal with it. Level 2, you have brief education. The treatment plans might include physical health goals. But level 3, you have ongoing education throughout the continuum of care and your service continuum. So you continue to monitor and you continue to provide that education and support. The skills are included in the treatment plan. And again, you're doing this with a health system so that your model of self-management is the same that they would be teaching and providing. Multidisciplinary teams. So it's really important that we work together and that our team is working with the physical health provider teams. Most of the physical health provider practices now have teams. And again, I'm not going to go through each one of these. You can, once the paper is published, you can spend quite, time looking at specifics. But I just wanted to highlight a couple of things. So with the level 1, the team really surrounds the patient. So you have a care manager, you have a provider, family, and patient, and that's kind of what the team is. In level 3, you are interfacing well with the physical health team, whether they're in your building or part of your agency or down the street. Behavioral health team members include care managers, social workers, case managers, therapists, and peers. And again, you're all working together through the continuum of care. For sharing treatment information and case reviews, level 1 is the routine exchange of information. And level 3 is you're actually meeting together and sharing plans, care plans to create a unified plan. And again, training. So I'm going to jump down to the social determinants because I don't know why they put measurement before social determinants. So let's go there. And it's extremely important because if you don't deal with them, whatever your attempt to do with population health is not going to work. Level 1, basic screening and referrals. Level 3, detailed assessment, and you're meeting with the other agencies to share information and talk about complex consumers. Okay, measurement in QI. And you really need to measure to make sure to have success. Here I just have what level 3 is. So you routinely incorporate physical health metrics with ongoing systematic monitoring of the population and to check with improvement. So let's talk a little bit about outcome improvement. The degree of improvement is related to what your practice was before. So if you're already doing a lot of level 2 integration and you move to level 3, your improvement may be small. If you were in level 1 and you go to level 3, your improvement will be much better. And it's also dependent upon what your local health system does. So if your local health system is very patient-centered and excellent in engagement, and the providers feel very comfortable with the SMI population, you may have less improvement as you integrate on your side because they're already screening and taking care of the physical health problems. So the measurement of improvement is not so important or informative than what the target is and where you are in that target. The goal should be that the outcomes are similar as seen in the general population receiving the standard of care. So it doesn't matter if your improvement is small or improvement is large, it's if you reach that target. So if your improvement is large, but you haven't reached that target, you still have a lot of work to do. It's very important to know what the literature, so what is the percentage of in the general population who has hypertension have difficulty reaching control, or stay at high levels of blood pressure, regardless of the medications prescribed and might need other treatment modalities. What is the target for diabetes in the general population? So we have to know that information to know if we reached it or not. So I want to talk a little bit about CCBHC. CCBHC has, I think, 9 services that they need to provide. You can see there at the middle right, outpatient primary care screening and monitoring. In the middle is screening, assessment, and diagnosis, but that's behavioral health mainly. So when you look at what's required for CCBHC versus what's required for level 3 integration, CCBHC is actually level 2, as is the health homes. And level 2 is another name for level 2 is comprehensive case management, and that's why it's kind of confusing because that's also one of the domains. But they really focus on coordinating care, though they have some language about population health. They don't have all the components of level 3. And if you look at level 3, these are systems that are joined together. So the Native Alaskan system, the VA, where they really integrated primary care and mental health integration. So they're one system. They may not be in one building, but they're one system. The other health system, ACO. So what do we need to ask the state to support full integration? Help in involving the payers and health systems. They can do that through a whole variety of ways. The health systems are doing behavioral health integration within themselves. So taking care of the mild to moderate, a lot of them are developing ways to do that, but not, they don't have much incentive to interface with us. Uniformity in care pathways, like I talked about, the one state where they had a consultant help meet with all the hospitals and all the behavioral health providers to have one transition of care model. So that really needs to align with the health system geography and not necessarily with the CMH geography. CPT codes availability that are available, some commercial insurances and sometimes Medicaid, but often not. And those are some examples of the codes. And especially the last one, where interprofessional telephone or electronic consultation. Provider can talk to another provider and discuss the case, and the physical health provider will be reimbursed. If they're reimbursed, they're much more apt to do it because they're under the same productivity pressures as the rest of us. It's overall simple in concept, but there's very specific elements that have to occur. So I talked about a simple definition of integrated care. This is the complex or the technical definition that's in the paper in any physical health or behavioral health setting. So again, they're talking about both settings. Integrated services means the provision and coordination by the treatment team of person-centered and appropriately matched interventions for both physical health and behavioral health conditions, along with attention to social determinants of health in the setting in which the person is most naturally engaged. I don't find that definition as helpful, but that's the definition that they have adopted and that SAMHSA has adopted. I think the purpose is extremely important, and we have to keep focus on the purpose as well as the outcomes, or the purpose is the outcomes. We have to eliminate early mortality and morbidity associated with a lack of comprehensive treatment. either in the physical health or the behavioral health setting. So it impacts not only the people we serve, it impacts all of us individually. To get full wisdom, like the slide there on the right, refer you to the paper. Again, it should come out next week during NACCOM, and the National Council will have multiple webinars on this, and there will be some presentations at NACCOM on this as well. But any questions that I may be able to answer? So I know it was a lot of material, but I think it'll make it much easier to read the paper.
A question is, what do you feel is missing from the definition of integration?
The importance of both systems working together. They emphasize in the setting where the person is most comfortable, but that would assume that every behavioral health center has a primary care physician embedded, and that's not always possible. And if you develop chronic conditions, you're going to be referred out to specialists. So it goes beyond the setting where the person's more comfortable. And one of the jobs that we have to do as behavioral health providers is to help individuals become comfortable and be able to deal with the burden of the chronic condition as well as the treatment requirements. So it misses that part.
Yes, I was wondering how you envision at level 3 the physical health providers, like currently if you're going to get services from community mental health and you have your own physical health provider. So would they mean that you only have coordination with certain providers? I mean, I don't see how it works.
Okay, that's an excellent question. The CMH for, Central Michigan, where I work, we have over 600 providers, physical health providers. So how do we coordinate with all of them is a very difficult proposition, but having clinical pathways and dealing some with the health system is very helpful. As a patient, what you would notice is when you come to a CMH would be that the person served coming to CMH, that they would have a lot of physical health screening done. They would ask you a lot of questions to assess what your needs are. How are you doing with engaging with the physical health? What your health literacy might be? Do you have difficulty navigating the physical health? What do you need to help if you have a chronic condition for you to feel better? The other things happen behind the scenes. So if you share, gee, I began to have some chest pains and I haven't told my doctor yet, and I'm thinking it's from my stomach, I have some indigestion too. And we say, gee, you really need to go to your medical doctor. We might say it would be okay if we call together because I'm really concerned about your description. And we set up an appointment. Do you need transportation? So those are the things that you would see. If you go to the medical doctor, we would follow up and make sure that you went, and then we would get the record back. So that would be behind the scene, but we would be able to understand what's going on with you, that we would be able to assure that the medical doctor is pursuing it and that they're not discounting your symptoms. And also, if you prescribed any medications, we can assess, gee, the medications that we're giving you might interfere. So maybe we need to adjust or talk to your medical doctor about some medication interactions or other options.
So as far as the the electronic health record being can't say the word, I'm sorry. But like between the private physicians who are not like in a Medicaid health plan or something, but is there something being developed? I know there used to be like the Great Lakes something or other and another one, but not everyone uses it. So
right. So right now, that's a huge barrier. Records have to be faxed or emailed or, sent over paper copies, scanned in. PCE currently does not interface with Epic well. PCE is the program that most CMHs use, and Epic is the program that most health systems use. The state has a pilot on a third kind of program where both CMH, PCE and Epic would dump their data into. So then you can see everybody's data. So the state has a pilot to see how well that works. So hopefully that will happen soon, that everybody would have access to that. Patient experience in level 3 is that we would, be monitoring and supporting throughout the whole time that you're with us, and that what you hear from us and what you hear from the medical doctor would be the same message. The things that you may not see is the population health that we're doing, but the purpose of that is to stratify, to make sure that everybody is getting the treatment or the support that they need. So if you have many medical conditions and social determinants of health, you need a lot more support than somebody who might have one mild condition. And so that we're putting the energy where the person serves needs are.
We have another question. It says, how do you see this information getting to the providers and private insurance systems?
Well, that's an excellent question. I intend to send a paper out to MSMS and other medical associations, possibly having meetings with them to see how they feel about this. The legislature may have to get involved with making sure that there's codes to support this. And some insurances like Blue Cross has many codes to support integrated care. Some of the other commercial insurances may or may not have. And I don't know about the Medicaid health plans, if they cover these activities or not.
On the issue about codes, so our local CMH has nurse care managers as part of the CCBHC, but they were saying they can't bill for them because to the state, because the codes haven't been turned on and the codes are locked and they're only unlocked once a year.
Mm-hmm.
So they need the CCABHC funding to continue to pay for that special service. Like, what does that mean? Lock and unlock and turn on and turn off these codes?
Right. So there's a whole bunch of codes that have been published. And I think the AMA, American Medical Association, is part of developing these codes. And then different insurances say that they will either cover it or not cover it. So if the code's turned off, means they're not covering that code or that activity. So for the CMH system, the way we're funded, care management is not something that you can account for. So that activity gets wrapped into other costs. So it seems like our costs are very high. And that's because we can't account for all the things that we do. Other private insurances may decide we're not going to cover care management. And so those patients don't have access to care management. And I think the state only looks at the codes once a year of whether they're going to turn on or turn off the codes.
Thanks. This is really very helpful. Who would be involved in making the plan for implementation of this model? And I can see it being, we have had, for example, the Duals project many years ago, which was focused on complex coordinated care, similar to this, not as complete. And the focus on that decision was made, seems to me, on basis of these were the most expensive and the most people at risk. So there was a focus on a population and a purpose and an implementation plan. Is there an implementation plan for this? Or is it, are we just at the model development stage?
Well, all of you are probably the first ones outside of the National Council to hear this presentation. So, a lot of people at the state have not seen it. So the model has been developed, and that's what's in the paper. The next step is, how is the state going to implement it, or are they going to leave it up to individual choice, individual CMH, individual health system? And are the health systems going to do it separate from the CMHs? Can we do something either through legislation or through MDHHS where we ask for a more comprehensive plan? And again, it has nothing to do with funding stream. It has nothing to do with politics. is getting these systems together.
If I may, I'd like to speak to that. One of the things I forgot to mention is that these presentations are not focused on the politics of integrated care at all. And I forgot to mention that at the beginning of the presentation. But one of the things that is striking to us at MHAM, particularly to myself and Dr. Pinheiro and I have talked about this, Michigan is one of the last states in the country to have addressed integrated care at all in law or in any way, shape, or form. And I know this because I've had this conversation with Mental Health America, which is our national organization. What I think would make a lot of this political stuff go away is if the state of Michigan would adopt a model and say, this is what we're doing. And what would really be beneficial is if they created a coalition across behavioral and physical health, public and private, payers and health systems, where everyone got in a room together and basically thought about what would the best system look like for everybody. That would be the most effective resolution to this. Not sure
Right.
that will happen, but the other piece is, at the very least, a definition of integrated care in law. Something to at least start the conversation moving in a direction which should be about what's in the best interest of the people more than anything else. But you need to have all of the players at the table.
It is so important because it's not just a specific population, it's all of us. You know, all of us will develop a chronic condition at some time in our lifetime, and we want our physical health provider to be integrated, to understand behavioral health and screen us for it, as well as, of course, the population that we serve, that we're so dedicated to. Let's not let them die 25 years early, but let's do what it takes. And now we have a model with very specific components, and the main decision that has to be made is, you know, how are the components going to be kind of put together by the systems, rather than which components do we put in.
I was wondering, since CCBHC is at level 2, how does that work with what you're working towards? Because right now I see CCBHC is very beneficial to a lot of people. I realize it's not to level 3, but do you see not eliminating CCBHC, or it would be a whole different?
No, because it's very important. I mean, if you're at level 1, getting to level 2 is extremely important, and it does create value and better outcomes. But what I'm saying is you shouldn't stop at level 2. And again, to get to level 3, you have to be able to do what's in level 1 and level 2. So you have to be able to do CCBHC before you do level 3.
So that would be, you know, how Senator Shirkey says that that's not integrated care. Well, it's not fully integrated care, but that would be your response, is that you have to get to 2 before
Right.
3.
Before you get to 3, it starts to involve the physical health providers with, you know, agreements that you have to develop. So it starts that process. Sometimes those agreements are not quite as jointly developed. And some states have naturally taken CCBHC to the next level by saying, we're going to do this systematically across the state and look at whole populations and data and stuff like that. So you can turn the CCBHC initiative to level 3, depending upon how you implement it.
Thank you. I hadn't thought of that. Thank you very much.
It's a really good question, Pam. Thanks for asking that question.
I think something that moves toward implementation and sort of a determination of which populations will be most politically, and I mean politically not in a partisan sense, but politically in terms of sustainable financial sense, that is the allocation of resources, is a political decision. Which populations would be most likely to be supported in a political environment? I mean, obviously it seems obvious to me we can't do all populations at once, populations, I mean, children and old people and everybody in between. I don't know if that, so I think what would be some of the ways we could move toward implementation? And one of the basic decisions I think we should talk about is how to chunk this in terms of populations and start with the most feasible, financially sustainable group, and then spread it to others, or have some discussion of the feasibility of implementation. I mean, I'm glad you're nodding your head. I'm not sure I've made any sense.
Oh, no, that was excellent. And the paper does address that. So we can certainly go over that and we can talk about ideas among ourselves. But that is an extremely important question, is how do we implement this?
And how do we educate people across the state, the citizens of all population groups, about why is integrated care important? Why we should be treating the whole mind and body, right? Not just the mind separate from the body. And what does that look like? When we started this, it was the first webinar, this webinar, and then a third webinar. But frankly, given the fact that this is a topic that keeps being recycled, I would like to think that these would be ongoing conversations, not just one or two, 2 or 3 webinars, where we would really be taking a long look at where do we go from here. Well, I want to thank everybody for coming, and I appreciate you taking time out of your Wednesday evening to spend it with us. I also really want to thank Dr. Pinheiro for sharing her wisdom and expertise and knowledge with us as well. We're really fortunate to have her. And again, if you have any thoughts or ideas or suggestions, please email me. And I also encourage you to visit our website, which we just unveiled not too long ago, completely redone, lots of resources on there. And when we get this, some of this, there's another integrated care survey that was conducted by Oakland University School of Public Health graduate students that we'll be sharing as well around this similar issue. We're going to stay on top of it because we know that this is not a conversation that's going to go away. And at some point, the state of Michigan is going to have to figure it out. And we'd like to have those that will be affected by whatever's decided to have the biggest voice in the conversation. So,
Marianne, are you able to post the paper once it's out?
Yes, we will. We will make sure that we put this, we'll work with Kristen, put it on our website. I'll leave you with this thought. One of the goals we have at MHAM is to take the politics out of the healthcare discussion. Mm-hmm. That is the goal, and to educate people so that they can make informed decisions about what they want their healthcare to look like. So stay tuned. Thank you all for everything, for participating, and I hope you all have a wonderful evening and a great rest of your week. Thank you.